Welcome to the image analysis on the knee. We're going to start with the AP projection. For the AP knee projection, image analysis guidelines state that the femoral epicondyles are in profile and the femoral condyles should be symmetric. The intercondylar eminence is centered within the intercondylar fossa. The tibia superimposes one half of the fibular head. The patella should lie just proximal to the femoral patellar surface and is slightly lateral to the knee midline. The intercondylar fossa is partially demonstrated as a small arch between the condyles. The femoral tibial joint space should be demonstrated as open. Anterior and posterior tibial margins are aligned. The fibular head is half an inch distal to the tibial plateau. The knee joint, or femoral tibial joint, is at the center of the exposure field. 1/4 of the distal femur and proximal lower leg and the surrounding knee soft tissue are to be included within the exposure field. In the supine position for the AP knee projection, it is the thickness of the upper thigh and buttocks that determine how the lower leg and tibial plateau will be aligned with the IR. Here, I have provided you a image of the central ray angulations for the AP knee. Patients who upper thigh and buttocks measure 18 centimeters and below, you're going to use a 5-degree caudal angle because the tibial plateau is placed more caudally to the IR. In patients who measure between 19 to 24 centimeters, a perpendicular central ray is sufficient. And those patients who upper thigh and buttocks measure 25 centimeters and above, you're going to use a 5-degree cephalic angle. So let's take a look at what happens when the central ray is not appropriately aligned with the tibial plateau. In this first image, you can see that our knee joint on the medial side is closed. This is a result of excessive cephalic angulation. When the knee joint is closed, we can determine that poor central ray angulation by judging the shape of the fibular head and its proximity to the tibial plateau. If the fibular head is foreshortened, as in this case, and is demonstrated at a distance that is more than half an inch distal to the tibial plateau on an AP knee projection, then the central ray was angled too cephalic, too much cephalically. In order to correct this, you're going to need to redirect that central ray 5 degrees caudal. So I like to think about looking at the projection. Is my joint space open? No. Where's my fibular head? If my fibular head is foreshortened, then I turn my central ray towards the direction that the fibular head went in, and it went caudally. Just a little tip or trick, but your original angulation was too cephalic. When we have a closed knee joint, as we do in this projection, again, we're going to look at the fibular head and which direction it went in. Looking at this fibular head here, it looks elongated this time. So our central ray was actually angled too caudally, and we need to redirect that central ray towards the head, or towards the direction that the head basically went in. And so we're going to angle the central ray 5 degrees cephalically to correct this central ray angulation. So let's take a look at how we determine rotation in the AP knee projection. When the knee is internally rotated, you're going to see that the medial epicondyle ends up being closer to the IR here in that internal rotation. And so it's closer to the IR than the lateral, decreasing its magnification. This results in the lateral epicondyle appearing larger than the medial because it's more magnified. Also, you want to look at this relationship of the tib fit. The fibula starts to become a less superimposed. And so right now, with this projection, we would need to repeat this because it's not in a true AP projection. Your fibular head should be superimposing half of the tibia, or the tibia should be superimposing half of the fibular head, and your epicondyles need to be parallel with the IR. An external rotation, that lateral epicondyle ends up being closer to the IR, which decreases its magnification, and increasing the medial epicondyle's magnification. And so it will appear larger than the lateral. Additionally, the tibia will superimpose more than 1/2 of the fibula. In this instance, the tibia is superimposing the entire fibula, practically the entire fibula. So we will need to repeat this image to get a appropriately positioned AP projection. So let's take a look at our first practice analysis here for the AP knee. The first thing you want to ask yourself, do I have all my anatomy? Yes, we do in this projection. The second thing we want to ask ourselves is my joint space open? And you can see that medial joint space is not open, but the lateral is open. So this should automatically tell you that we have some type of central ray angulation issue. We also want to determine if we have any rotation. And then, as you recall, the tibia should superimpose 1/2 of the fibular head. But because of the angulation issue, it is not quite there. So there's no rotation issues, it's more angulation. As you can see, the fibular head is foreshortened and is demonstrated more than a 1/2 inch distal to that tibial plateau. So when the head is foreshortened, we need an angle towards the head. So we're going to adjust the angulation caudally, because the central ray angulation for this particular projection was angled too cephalically. In our next AP knee practice analysis, again, you're going to identify if you have all your anatomic structures, which we do. However, we're taking an AP knee projection, so we also need to have an open joint space. And looking at both the medial and lateral aspects of the joint, it is open, so our central ray is good. Now we need to determine, is there any rotation? And so with that being said, you want to look at that tib-fib relationship, and it's starting to get superimposed. The medial femoral condyle appears larger here than the lateral. The tibia superimposes more than that one half of that fibular head, so the leg was rotated externally. In order to correct this, we need to internally rotate that leg until those epicondyles are parallel with the IR. Let's continue on to our AP oblique knee projection. Image analysis guidelines for the AP oblique projection, specifically the medial oblique, states that the fibular head should be demonstrated free of tibial superimposition. The lateral femoral condyle should be in profile without superimposing the medial condyle. For the AP oblique knee projection and the lateral rotation, the fibular head is aligned with the anterior edge of the tibia. The medial femoral condyle is in profile without superimposing the lateral condyle. The patella should lie just proximal to the femoral patellar surface. The endocondylar fossa is partially demonstrated as a small arch between the condyles. For both the medial oblique and lateral oblique, image analysis guidelines state that the femoral tibial joint space should be open. The anterior and posterior tibial margin should be aligned. The fibular head should be demonstrated a ½ inch distal to that tibial plateau. The knee joint should be centered at the exposure field, and 1/4 of the distal femur, and proximal lower leg, and the surrounding knee soft tissue should be demonstrated within the projection. For both obliques, we know that we must rotate the leg either internally 45 degrees or externally 45 degrees. When there is insufficient internal medial oblique rotation, we want to look at that tib-fib relationship and determine whether it's open. In this projection, the tibia is partially superimposed the fibula, so therefore we are insufficiently rotated, and we need to increase the rotation until the epicondyles are at a 45-degree oblique with the IR. In excessive internal rotation, we can determine the degree of obliquity by looking at that tib-fib relationship. We're almost in a lateral projection, as you can see. The fibula is not superimposing the tibia, so we need to bring those epicondyles back down to that 45 degrees in order to open that, or to get that the epicondyles 45 degrees with the IR. Please continue to part 2 to complete the image analysis.